Yeah, we did part of this the last time that we were together, so this is part 2. This is the only time that I'm going to cater to the Canadians.
Excellent. Well, folks, it looks like we have a good group here. I'm going to give you a couple of little quick details. I noticed you were all good about putting your class at the end of your name. Thank you for that. You do have to participate to get credit. I know at least one of you is on duty, so if you have to leave, just post in the chat box 911 or something so we know you're gone. I'll try to give credit depending upon how long you've been here before that happens if you need credit. Like I said, you will have to participate. Dr. Phillips may ask you questions. If you have questions, you can unmute your microphone, say Dr. Phillips, or, and take a breath. If you don't have a microphone, you can type in the chat box, and we'll try to pay attention to that over there. But I know it's difficult for Dr. Phillips while he's rolling along to try to watch that chat box too. So do the best you can, but we'll check in on you again at the end. If you need MD Roundtable credit, of course, at the end, as long as you participate, then I will grant that credit for you. If you have already achieved that, those 3, but you still need a chat room credit, I'll grant you chat room credit, and the same goes if you are not in 400, which I guess Hudson just had to go run on a call because he was the only one not 400 tonight. So that having been said, I'm going to mute my microphone and turn this over to you, sir.
All right. So I tell you what, at the end, we'll kind of just briefly go through the previous slides just so that we can see if there are any questions that came up since then. So let me get to, there we go. So there's for your pharmacology, study everything. So the first thing, controversial, and it's not really a drug, I guess you'd say, but it's blood. There are some definite indications for this. They're talking about this being low titer O positive whole blood. So not quite the universal donor. O negative is considered to be universal donor, but O negative is so hard to come by. And the positive Rh factor is for men is not an issue really. The issue becomes for women that are O negative or any kind of Rh factor negative, that they may become somewhat immunized and develop antibodies to the Rh factors. So that's really the big problem. But the big question is, does it improve outcomes in trauma? And so you can actually thank the folks down in the San Antonio trauma service area for a lot of this, because of course they have Brooke Army Medical Center, Wilford Hall Medical Center, the trauma centers there in San Antonio as well. Of course, Brooke and Wilford Hall are all one now, but they have a tremendous military medical component that they kind of draw from. So they get a lot of information that probably is a little bit more difficult to come by in the civilian sector. So here are their transfusion criteria. If it's penetrating trauma, they have to have one of these physiologic parameters. If it's blunt trauma, they require 2. Now, shock index is one of those things that we're not going to necessarily be calculating, but there is actually a shock index, and I think that it's probably more in the military community, but some civilian sectors are using it as well. But if you notice the other 3 at the top there are very, very simple for us, because I mean it's vital signs. So the blood pressure, the heart rate, and then the pulse pressure. So we'll just pick on Kyle, since Mr. Luckett there, you're at the first of the line. How do you calculate the pulse pressure? You can either unmute or you can put it in the chat box. Obviously, we're not going to be doing a point of care lactate in most systems, and very few of us are going to be doing the FAST or the ultrasound examination. So anybody else want to jump in there with how you calculate the pulse pressure?
Systolic minus diastolic.
Go ahead.
Oh, is it the
yes, systolic minus diastolic.
There you go.
Yeah, very simple math. So it's not the same as calculating the mean arterial pressure, where you have to do a whole bunch of math formulas to get to that one, and you really are better off using a calculator. Pulse pressure, you can just do that one real quick in your head. So dual antiplatelet. Now, they talk about presumed anticoagulant use. So there we're talking about Eliquis, we're talking about Coumadin, those sort of medications. Now, when they're talking about dual antiplatelet, okay, it used to be real simple. It was either aspirin or Plavix. Those are the only antiplatelets, and usually they would combine the two of those. Now we have Brilinta as well, and I think that there's one other. So sometimes I'm sitting here having to pull out my phone and look these things up. And then other signs of hemorrhage and patient age greater than 5. So they have to be more than 5 years old. So John says, is there a specific transport distance that should be used when EMS services decide whether or not to carry blood or TXA? Yeah, that's an excellent question. We're going to kind of get to some of those issues in just a little bit, but that's an excellent question. And those are some of the questions that I have as a medical director. So let's go on here. So as of October 14th of last year, these are the places that have blood available. Okay, now you notice there's actually quite a few of them inside of San Antonio proper. And there are also some that are pretty close as far as their transport time into San Antonio. So that kind of answers John's question there of, is there a set time frame? And yes and no, there is and there isn't. I think it's interesting that they have not reached out as much into the rural areas, with the exception of on the helicopter. And there's a good reason for that, and that is so little are they going to be using it. And so it's a lot easier if you have it where it's going to be utilized in a fairly often manner. So here is one of the other that are pictures from the STRAC, and they talk about their whole thing here. So they have the donor, and it goes for days 1 through 14 to the rotation site, and then 15 through 35 it goes back to the rotation center, and at that point it actually goes to the hospital so that they can try to use it before it expires. So it's only out there for 2 weeks at a time, and they have 35 days total in which to use it. So as you can tell, it's very perishable. And then there's also quite a few other things that, as a medical director, I'm going, those are some difficult sort of things to keep up with. So I'll tell you my opinions, okay? You look at the data, and this is data that is all available on the San Antonio TSA's website. From January to September of 2018, they used it 30 times. That's it. So roughly 3.4 times a month. They do have the rotation system, but they're not telling us how often they end up having to waste those units. And I don't know, and I need to contact, I've actually got a pathologist friend that is a transfusion pathologist. And I need to find out, is this something that they would be able to split into components later on? I don't know the answer to that, because if it's components, it's more likely to be used. And then the next question is, does this overall affect the blood supply? They've actually identified, they call it a walking donor pool of people that are O positive, that are willing to go and donate whole blood on demand, basically. I think that that's an excellent sort of program. The problem is, I don't know how easy it is to get that same sort of thing in other sites. So any questions at this point about the low titer O positive whole blood?
Dr. Phillips, I've got a question. So when it comes to the low titer O positive, this data from 2018, wasn't there still kind of a hesitancy for every hospital to be using this for resuscitation still? And that's just coming from the data that's coming out from the military recently.
Well, it actually is one of those where it kind of depends on the providers and what their medical directors have been pushing. I know that there are, I want to say it's PHI, and I want to say Air Evac, even in our area, is carrying whole blood for traumas. It's not something that is used very often, and I'm working at a level 3 trauma center in Texarkana, and as I've never had anybody brought in with whole blood hanging, and I don't know that any of the services there even carry it. I know that the ground units do not, but then again, they also have a huge service area for that particular service. So, I would think that if there was enough support there, they would do that. I don't believe that for the most part, the field medics that I've talked to have been hesitant to give it. And in fact, I've got a lot of mine in the Parker County area that are asking, can we please do this? And my question is always the same. And that is, what's the cost going to be? How often are we going to do it? And is it really going to change outcomes? And the problem is I don't see us using it even once every 3 months at our service. Keep in mind that 3.4 times per month was with the initial rollout in San Antonio throughout that entire rack. And that's in a community that is very gung-ho about it. So, but excellent question. So Dustin asked, what exactly does low titer mean? So we know about the ABO antibodies, and we also know about RH antibodies, but there are a host of other antibodies that are in there. So when these donors are screened for this, they actually look to see, do they have a lot of antibodies in their blood? If they do, then they would not be suitable for this program. So that's what low titer means. So, but excellent question. Let's see. Female with thrombocytopenia in the J&J vaccine, is there any specific to consider the blood products for these unique patients? They would say no. If they're bleeding, give them the blood. And also, especially since it's whole blood, it has the platelets in it. And so that really, I mean, we've had some issues with the massive transfusion protocols because you need to give platelets along with packed cells. And if you meet a certain threshold of number of units of packed cells, you really got to put some platelets in there as well. If you're giving whole blood, you don't have that consideration. It's there. Actually, Dustin, no, it doesn't have anything to do with vaccines. The antibodies are antibodies that are on the blood. There's over 100 different possible antibodies that are native to our blood, and they're DNA sort of things. They're things that are coded in your genetics. But actually, that's a great question. What is significant about the transfusion criteria of less than 45 on the pulse pressure? So granted, yeah, but with your standard vitals of 120/80, that does not, because once again, is it in the setting of blunt trauma? Is it in the setting of penetrating trauma? Is there evidence of bleeding? So once again, you can't just take that one little thing and say, well, they have this. It needs to be in the setting of trauma, and there needs to be some evidence of bleeding. But good question, Albert. Anything else?
I have
We
a
hit a
question
chord.
real quick.
Yeah.
Uh, I'm guessing that the blood is stored cold while you have
Yes.
it. So is there a concern? You're already concerned in trauma with hypothermia. Is there even more of a concern for inducing hypothermia or a more profound hypothermia with giving whole blood? Or is that
Well,
just kind of
and
like a background thing because they're bleeding? The blood is more important.
well, actually, you're correct on both accounts. In general, there is some kind of a warming device that is used, but it doesn't have to be that way. Frequently in the ER, if we're giving blood, especially to a trauma patient that is crashing, we got to get the blood in there. We got to get some way for them to carry oxygen. So that's the most important part. Um, but in general, these systems have blood. Yes, it is refrigerated. It has to be kept at a very narrow margin as far as the temperature, so it is very well controlled. But then there is usually some kind of a portable warming device that the fluids are going to go through in those situations. Good question, Carla. So no, we don't have scribble in stock. In case you've never seen our handwriting, that's actually going away since most of the things these days are actually sent electronically. So let's talk a little bit about pain management. First off, understand that there are numerous things that can help with pain. Let's not forget the basics, okay? Non-pharmacologic interventions have great impact. Seriously, these many times can achieve much more than even medications can. And water rocks are great. That's ice if you didn't know. So I love this mnemonic, splint. So splint them, drugs are possible. Elevation helps. Ice, once again, the water rocks. Neurovascular check and talk to them. A lot of times these are the things that are going to help more than anything. And really the pharmacology, if I could do this over and make it something that made sense, I'd put the pharmacology down as one of the last things. So let's talk a little bit about a parenteral. So we have non-opioid, and then we're going to talk about a few of these things. And then we have the opioids. So acetaminophen. First off, Ofirmib is an IV acetaminophen preparation. It's one that has been used for a while. I like it, but at the same time, it's also pretty expensive. And Dustin and I agree completely. Humor does help, but you got to be careful and select the patient carefully for those sort of things. I was joking around with a patient the other day in the ER, and they said, "Are you trying to be funny?" Well, yeah, actually, I was. Apparently, I'm not. Okay, we'll move on. So the IV acetaminophen, the cost is around $40 a dose. At the same time, the freestandings where we were using it, they were charging like $300 for it. So it can be very expensive. And then, I like Chris, great results with it. Had hernia surgery in Egypt and pain controls IV Tylenol. Here's the thing. When the manufacturer is not the one controlling the trial, it really has not been shown to be more effective in blinded studies where people are getting something IV and PO and they don't know which one is the active medicine. It doesn't make a difference. So there's not really any better efficacy by giving it IV. And there can be some issues, some reactions, not allergic reactions, but you can end up with some reactions to it. So it has to be carefully chosen. Frankly, I'm at a hospital where the entire system, none of the hospitals have this, and it's due to the fact that it costs too much and it hasn't been shown to work any better than oral. So Ketorolac. Now this one is one where it can work better, in my opinion. But once again, I think that a lot of that tends to be how I sell the medication to the patient. Um, you also got to keep in mind that it does inhibit platelet aggregation, and that every patient, young, old, doesn't matter, it will at least transiently inhibit the renal function. So you need to be careful, especially in older folks. It is usually well tolerated. Chris says great for kidney stones. Absolutely, it is. At the same time, when I send people out, I give them oral NSAIDs, and they usually do better with that than they do with the opiates. And then there's a reference for this particular information. So if you go back and you want to copy that down, you can actually go and open the same article that I copied that from, plagiarized. So now I'm gonna share with you. There was a study a few years back where they took children that had forearm fractures. All of them were closed, and in these kids, they asked the kids and the parents to rate their pain, and they double blinded these parents, kids, and the medical staff. Some of them got oral narcotics, opioids. Some of them got a combination of Advil and Tylenol. Nobody knew what they were getting. And then they graded the pain again. And across the board, with all of the kids, they got better results on actually treating the pain, reducing the pain, with the combination of ibuprofen and acetaminophen than they did with an opioid. So I've been taught since medical school that opioids don't actually take away pain. They just make it that you don't care that you hurt. So there is a place for these things. And so just keep those in mind. Some EMS agencies do stock ketorolac. And if they do, you need to be kind of careful in your patient selection of these. So everyone loves Toradol. So the NSAIDs, all of them in that class, all of the non-steroidal anti-inflammatories work on what's called the cyclooxygenase system, and that actually reduces smooth muscle spasm, and that's why kidney stones hurt so much, because the ureter is a tube that is muscular and it's squeezing urine down, and so that definitely always helps those people if they can take them. Some people cannot. So ketamine, we already previously discussed ketamine, so we're not going to talk about that one. If you have specific questions about it, we can come back and cover that in a little bit. So nitrates. This has to be limited to cardiac indications, usually ACS, acute coronary syndrome, and congestive heart failure. It's a potent vasodilator. It's available IV, sublingual, and even topical forms. For what it's worth, if you're at an agency that stocks nitro paste, I tried to actually get the NitroDirt patches. It's the exact same. It's just that you don't have to worry about getting that stuff all over your hands, and then you do this, and then you suddenly wake up on the floor because you hit the floor because you vasodilated yourself. I've had patients that with the spray have had the nurse come and give them a spray of it for their chest pain, and then they turn and they answer the question that I just asked them, and it blows right in my face, and I've gotten horrible headaches from nitroglycerin as a result of that. So you do need to be careful when you're handling this stuff, because it can cross your skin, and heaven forbid if you accidentally get the paste on your hands, because you will get a bad headache from it. So if you're at an agency where they have the paste, try to talk to them about getting the NitroDur patches. So excellent question, Chris. First off, my limit on that is dependent on the situation. You may have heard Jane talking about taking the patient to Abilene that had an inferior MI. In those patients, they're going to have to be probably 120 or higher on their systolic before I'll even talk about it. And then you better have some fluids running. If it's somebody that they have already taken some nitroglycerin of their own at home, sublingual, and they say, you know, it was getting better, but now it's come back, and you know, I took some more and it's helped, but it's coming back. Okay, you know what? In those people, I'm probably a little more liberal with it. You know, down to 100, I'm probably okay. But at the same time, when we give it to them, they're going to be laying down. That's all that I've got to say about that. So, David, you asked about ketamine versus fentanyl. They're two different drugs. They work different ways. We're coming to the opioids in just a second. Yeah, IV nitro. IV nitro is great because you turn it on, it's there. You turn it off, it's gone. But at the same time, you got to be careful, and that's why, you know, my lower limit is generally 100. And really, I'm getting to where I'm using the mean arterial pressure more. So I'm usually around 65. If their MAP is 65 or lower, they're not getting it. So when would ketamine be more advantageous than fentanyl? Well, let's talk about the differences in those in just a minute. So opioids. First off, the thing that differentiates all of the opioids is their potency. That's it. They all depress respirations, they all drop blood pressure, they all will help the patient so that they're not hurting as much, but the potency is really the main characteristic. Morphine does have more vasodilation, but they all can do that. And all of them, because they can decrease catecholamines, may actually improve your hemodynamics. So they may slow the heart rate down some because they're not feeling as much. They're not getting that catecholamine surge. So there's advantages to all of them. And really, rather than saying that one is better than the other, I think that it really is a matter of knowing the pharmacodynamics and the pharmacology of each of them, and being willing to say, okay, you know, we got a long ride ahead of us. Maybe hydromorphone Dilaudid may be a better one because it's going to last a little longer. I've got somebody that their blood pressure is elevated. Maybe the morphine's a better one because it's going to drop their pressure a little more. Or I've got somebody that I just need to get something, you know, put a splint on them. I want something that's going to work quickly, but wake them up pretty quickly as well. So fentanyl may be a better choice. So, you know, those are all some of the things that, once again, study all of the drugs, get to where you know them inside and out. But keep in mind that all the opioids basically work the same way. They work on essentially the same receptors, but some of them have more potency, some of them last longer, and that's really the biggest difference. So here is a chart for equivalencies. So if you would ordinarily give 10 milligrams of morphine, which in my opinion, that's a pretty big dose. I usually start out at 4 to 5. Then the Dilaudid equivalent is 1.5 milligrams. And I usually start at 0.5 to 1 milligram of Dilaudid. That's just my starting dose. Fentanyl, generally, I start out at 0.2 milligrams or 200 micrograms. That's usually my starting dose for that one. Once again, fentanyl is a very short acting one. So once it's there, if I have a problem, it's going to go away pretty quickly. Morphine is kind of in between, and Dilaudid tends to work a little bit longer. Now, you heard me mention Paul Smith. Paul actually was a patient of mine at one point, and I know that he won't mind me sharing this particular one. We gave him some Dilaudid, And at the time we we gave him fentanyl. And at the time we were carrying fentanyl in the ambulances at Life Care. And I gave him 25 micrograms or 250 micrograms, 0.25 milligrams. And his comment was, "Oh my God, that was a lot." And I'm like, "No, that's actually starting dose." And I said, if you look at some of our reports, some of our people are given 500 micrograms, 0.5 milligrams to start with. And once again, it's all about the selection of the patient, realizing that their blood pressure can handle it. And, are they somebody that's opioid naive, or is it somebody that takes them on a regular basis? And the other thing that I try to tell people all the time is you can always put a little more in, but it's hard to take it out. And especially with opioids, if you reverse them, then they're going to be hurting for a while because you're not going to be able to get their pain back under control. So just kind of keep that in mind. And I say that all the time, so I'll say it again. It's easy to put some more in. It's hard to take it out. So let's talk about opioid dependence. Anybody have any questions about the equivalencies or anything before we get to this? Okay. So keep in mind, a single dose of opioids is not going to cause somebody to become an addict. Okay. It will not do that. Withdrawal is a real problem, but keep in mind that that is not a life-threatening condition. Nobody has ever died from opioid withdrawal. Now, I can't say the same thing about benzodiazepines or ethanol. Both of those can be life-threatening withdrawal syndromes. But opioid withdrawal is not a life threat. It feels horrible. It feels like the worst case of the flu with vomiting, diarrhea, chills, sweats, the whole 9 yards. But again, it does not kill people. And anytime that you have a major traumatic injury, especially open fractures or burns, there really is not a good reason to withhold opioid pain medications. In fact, I've gotten calls for severe burn patients by my crews, and I've said this before, and that is your endpoints are either analgesia or apnea. So either they stop hurting or they stop breathing, so just give it to them. So let's see. We have a database that is used by prescribers and ED to track opioid. Yeah, actually, every state has to have that at this point. I don't see that as ever being a requirement for EMS agencies. And the reason for that is, first off, you're not prescribing to them. You're not going to be handing a bottle of pills to them that they can sell or whatever. And so that is, once again, for what we're talking about, especially an injury or something, that is not something that I think that you guys should even consider. I would much rather, and especially, I don't want you to end up getting threatened in the field, with, a weapon of some sort. I would much rather that you just go, okay, you know what, here's something that should help you. Okay, so Sydney, excellent question. Excellent question. Let me finish reading all of it here, but I kind of know where you're already headed with this. So we all have our little, I guess you'd say, things that we have, our stories, the things that we practice by. So here is the answer to your question. In 1992, when I started my EM residency, the first journal club that we had, we reviewed an article from 1991 that was talking about opioid pain medications in the acute abdomen. So in other words, a surgical abdomen. Somebody that may have appendicitis, or they may have bleeding in their belly or something like that. And in that study, what they found is that giving opioid pain medications did not mask the exam. And in fact, it improved the diagnostic accuracy. So let's fast forward 1999. I'd just gotten out of the Air Force and I'm at a private hospital, and I have a woman that has a tubo-ovarian abscess. She has an abscess in her fallopian tube. And so I called up the OBGYN on call, who were on a first name basis. And he goes in and sees the patient. He comes back out and he goes, "Hey, I'd love to take her to the OR, but I can't." I'm like, "You can't?" And he said, "Yeah, I can't do an exam on her." I'm like, "What do you mean she won't let you?" And he goes, No, you gave her morphine. I can't do an exam on her. It's not an accurate exam." So I didn't even do one yet. I'm like, "Why not?" And he goes, "Because I can't. You gave her an opioid." And I said, "Just go and examine her." And so he goes in and he comes back out about 15 minutes later and he goes, "Oh my God, I have never palpated one so easily other than when they're on the table and under anesthesia." And I said, "Yeah, and did she hurt when you pressed on it?" "Absolutely." Said, "You can do that." And at that time, I'd printed up that paper and I handed it to him and I said, "Here, this is about 8 years old." And so that was the first time. The next time that I ran into it, I moved back to Fort Worth. I'm working at the county hospital in Fort Worth, and I have an appendicitis patient. And the surgeon comes down, or I should say the surgery resident, and he goes, "Well, I can't examine her. You gave her some narcotic." And I said, "Yeah, so?" And he goes, "I can't examine her." And I'm like, "She's laying there sleeping. She's not going to stop you." And he goes, "No, it's not a good examination." I said, "Did you examine her?" And he goes, "No, I can't." I said, "Okay, first off, you get your literature, bring it back to me, but let's go and take a look at the patient together." She slept through everything on the exam until we got to the right lower quadrant. And then she woke up and goes, What? And I said, "There, she hurts there." And he goes, "So, I told him the reference." And so, at the same time, that is old information. That actually came out in the 1800s in Cope's diagnosis of the acute abdomen. So that is something that you need to just make go away. Don't worry about it. You need to ask your medical director to research the literature and to know that that's not the standard of care. The standard of care, even from the surgery side, is if you have somebody that has an acute abdomen, give them pain medicine. It's not going to mask their examination, and it will actually make it better. So fast exams make it very possible to masking the problem is a moot point. Absolutely. Um, so fast exams in the field, that may be something that we need to kind of consider covering at some point. I think that, and this is just my opinion, I think that pre-hospital ultrasound is coming. If you had asked me 5 years ago, I would have said, I don't see it for a long time. And I think that actually COVID has kind of started to kind of push that a little bit more. And in fact, I'm considering getting a handheld ultrasound for my supervisors and FTOs. That way we can train them. And then as the price comes down even more, we can look at that for the other units. My question with anything like doing an ultrasound or point of care labs is, what is it really going to change about what we do? Because if we're doing a fast exam, that's on a trauma patient. Are you not going to take them to a trauma center if they have a traumatic mechanism of injury, but their fast exam is negative? No, you're still going to take them there. Will the hospital activate a level 1 or level 2 trauma based on your fast exam results? They probably will activate in the ER. Will they have an OR waiting for you when you show up with it? Probably not. And that may change, but that's going to be a slow process. There are still some hospitals, even the Dallas-Fort Worth area, that if we call and say we've got a STEMI, they don't automatically have the cath lab waiting for us. And that's more a matter of we have to build our reputation. And it's going to be the same with ultrasound. Yep, David. One of our residents, when I was a resident, an upper level to me, had a disc, and he came in, he was sweating and could not walk until we gave him something. So anyway, I definitely agree. First off, you don't need to memorize a dictionary. You need to more learn a few of the categories and a few of the common drugs in each of those categories that are something that you're going to be seeing. I'm not going to know oncology drugs. I'm just not, because I don't run into those. And so, but at the same time, if you start asking me about, sedation, if you start asking me about blood pressure medicines, I usually will at least recognize a name. I may still have to look it up to see what class it's in, but once I get the class, I know what it is. So, those classes for medications generally are not going to change, but they may have something else that comes along. ACE inhibitors used to be a class all of their own. Now we have angiotensin receptor blockers, which is a subcategory of ACE inhibitors. So, you may need to learn some of those things, but the pharmacology generally is not going to change. So, tranexamic acid, or TXA. It's a lot easier to say TXA than tranexamic acid, and usually people don't know what you're talking about with tranexamic acid. First off, this is an old medicine. It's older than I am, only by a year, but it's older than I am. And it was initially just for OBGYNs, but they didn't have that much interest in it. And first off, that it was for heavy menstrual bleeding and also for dental extractions with bleeding. And still, those are the only FDA approved uses for this medicine. So kind of an interesting little tidbit there. It's synthetic reversible competitive inhibitor to lysine receptor on plasminogen, and the binding prevents plasmin from binding to, and ultimately it stabilizes the fibrin matrix. So in other words, your clots don't break down. That's really what this boils down to, is the clotting mechanisms that are there don't suddenly start turning on themselves and breaking down their clots. So some patients, and a couple of times with women that have had some heavy menstrual bleeding to the point where they're anemic, I have actually written prescriptions for an oral form of this, but those are pretty unusual for us. But it's one of those where if you see a medicine name that you don't know what it is, look it up. It doesn't take that long. You can download Hippocrates or Medscape. Either of those are great for looking at medications. You can also use them to identify pills. So just kind of consider those sort of things. Just look up the medicine. It doesn't take that long to do. Now, there were a series of studies called the CRASH studies. And you can see what CRASH stands for. And I think that's one of the requirements to get funding for your study, is you have to have a fun acronym or something that's memorable. But the CRASH has looked at several things. First off, CRASH 1 was about steroids. It was not about TXA. CRASH 2 was for TXA with trauma. And that did actually show that it had a significant effect that was positive for people that are traumatically injured. And then CRASH 3 is about TXA and traumatic brain injury. Interestingly enough, if you have a head injury that may have bleeding, it really doesn't seem to help. So kind of an interesting paradox. If you're bleeding elsewhere, it helps. If you're bleeding in your head, it really doesn't seem to. And those are studies that you can look up, and you can, I mean, they're not that difficult to read. There are a lot of statistics associated with them, but I think that especially for the crash 2, I think that that's actually an excellent study for you to go and look up and read about it. And once again, one thing that I try to stress with every student of every level that I have, and that includes even myself, that is, be skeptical of anything. Read the actual study, get to where you can kind of understand some of the statistics that are being discussed so that you can make an informed decision. You don't have to come to the same conclusion as the authors, because sometimes they're being paid to say what they're saying. So yes, it can be used for postpartum hemorrhage. Actually, it doesn't increase fibrin clotting. So one, it actually prevents the clot from breaking down. So that's actually been an interesting thing. And they have had some problems where sometimes the clots, they do end up breaking off, and so they can end up having embolization of different things. But those are some interesting sort of things. So Chris brings up surgical or non-surgical, and I'm assuming that you're talking about postpartum hemorrhage. That would be, they actually sometimes will use it during surgery, but it can even be for non-surgical. And yes, Benjamin, you're actually right. This is one of the things that did come out of battlefield medicine. Every time that there is a war, we do advance medicine because there are things that are done that we just can't do in a civilian setting. And so you hate to say it that way, but it's true. So, there are a lot of things that come out of those things that, and if you have to say that something good is going to come out of it, these are some of the things. The other thing that came out of the Middle East wars has been the field use of ultrasound. So those are some of the things. The low titer O positive whole blood as well. I think it's interesting, and you probably should consider, if you're in a system where they're giving the whole blood, if you're giving blood, you should go ahead and give the TXA as well. So it's also commonly used for epistaxis. That's actually the first place that I used it, and it worked wonderful. And I've used it several other times since then. It's just that we put it onto some cotton and then shove the cotton into the nose. And it's usually a strip of cotton that's about this long, and just dunk it down into the vial and just shove it in their nose. Works pretty well. Massive hemoptysis. I've never given it this way. And really, I've only seen one case of massive hemoptysis, and this was several years ago. But in those cases, they're saying that you can nebulize 1 gram in 20 cc's. So obviously, you're going to have to, draw up some, put it in the nebulizer, and keep drawing that up and putting it in there while you're transporting, if you're going to do that. So for IV dosing for trauma, 1 gram and 100 mLs that's given over 10 minutes, and then another gram that is IV piggyback over 8 hours. Generally, we're only going to give that 1 gram as pre-hospital, unless you're in an area where you have an extended transport. Then you may be forced to go ahead and hang the drip. But the really important part is, if you give this, you have got to let the hospital know, because you have to give that second dose. You have to give that 8-hour dosing as well. You cannot just do 1 dose of 1 gram. You have to give the second gram as well. And in pediatrics, this is one where I'm going to be having my crew call if they're going to be given, if they're going to even consider giving this, they got to call. Okay, Chris, you're going to have to draw up like 3 to 5 cc's. You can generally fit 6 to 10 cc's into a nebulizer. So you're going to have to draw out part of that, put it into the nebulizer, and then when it starts to run out, drop another, shove that in there as well. So yeah, it's broken down. So $50 a dose. For medications for pre-hospital, that is cheap. That is really cheap. So it's not something that's a huge expense. Granted, if you've got like the Life Care has 10 24-hour trucks. So we'd be looking at for one dose in each truck, $500 across the board to put one dose in each truck. And really, you probably better have 2 doses in there. What if you've got 2 traumas before you can come back and resupply? So, there is some cost, but it's considering other things that we have in those trucks, it's not that expensive, especially if you're carrying EpiPens. So before we move on, any other questions at this point? First off, racemic epinephrine, it's still out there. I still use it occasionally. That's an excellent question, Juan. And it used to be that we tried to avoid that because the saying was that if you gave somebody racemic epinephrine, you had to watch them for at least 4 hours. That's really a myth. You don't really have to. Frankly, I don't have an issue if a crew called me and wanted to use 1 milligram of epinephrine in the nebulizer. Just put the epinephrine in there. The racemic part of it really doesn't make that big of a difference. And yeah, especially regionally, there are a lot of variations in any of these. But I do still use racemic epinephrine. I do still use that, and we actually, with COVID, we actually brought back breathine, which is an injectable bronchodilator. So but the racemic epi is more used in kids, and I think it's a good drug. I just don't use it unless they're really, really bad. Good question. Well, 1 milligram is 1 milligram. So if you're using the 1 to 10,000, that's going to be in 10 cc's. If you're using the 1 to 1,000, that's in 1 cc. You can put that in there and then put a respiratory saline in there with it to make it a 3 cc updraft. So, you could do 10 cc's, but it's going to take longer to get that in. Generally, racemic epinephrine, it comes as a premix, and you just open the ampule and put in there. Good question. But once again, 1 milligram is 1 milligram. It's just concentration. Anything else? Who's been quiet through all of this?
Kyle Luckett. Haven't heard from you, Kyle. Haven't heard from
I asked him a
Carlo.
question I asked him the first question.
Did I miss that? I'm so sorry.
Yeah.
Okay, how about Carlo? Carlo, have you been participating?
Yeah, he sent a question or two on the chat.
Okay. There we go. He just sent another one.
Did you miss my question? That would have been the question I would have asked.
Right.
Okay, so is there a purpose to racemic epinephrine? Well, first off, supposedly the different isomer forms of that, and also albuterol, also known as Zopanex, the L-albuterol. Supposedly you're supposed to get less side effects with some of those, but frankly, I don't see that big of a difference. And once again, it depends on who's paying for it in a lot of cases. Back in early 2000s, Zopanex had just come out and it was already FDA approved, but the pulmonologists at the hospital that I was at were participating in a study, using that with people that had pneumonia. And so they came in and they were like, oh my God, this is the best thing ever. It's wonderful. You got to use this. Please enroll these patients. Of course, they're getting paid for enrolling the patients. We didn't see a dime of it, but they were getting paid for that. Once the study was over, suddenly it was like, yeah, you can go back to albuterol. So, once again, money makes the world go round. And so the racemic epinephrine, it's supposed to give you fewer side effects. Frankly, I don't really see that big of a difference in my own practice when I've used both of them. But that's the rationale behind it. Good question. So, antivenom. And yes, it actually is anti-venin. So, you're going to have to tune in next time to hear me say time is tissue. There will be cool snake pictures, and you're going to see why CroFab really is so danged expensive, in keeping with the last picture that we had. Any other questions?
Come on, folks,
Complaints?
now's your
Okay, Dustin, that hurt. That hurt. Yeah, I'm old. So the original TV Batman series from the 60s and 70s, now in color, at the end, it would always have a thing for the next one. It was, tune in, same bat time, same bat channel.
Yeah, I remember that too.
Phillips, I do have a question for you, and just so my background is combat medicine. I've been in the Army as a medic for the last 14 years, and
Okay.
we're seeing a lot of data come out of the direct transfusion stuff and low titer whole blood. And granted, I know it's not FDA approved, but do you see a time where that might become a thing in pre-hospital just because of the type of data that we're seeing coming out of the combat medicine as far
For
as
the
direct
whole,
transfusion?
oh, the problem really becomes one of FDA approval. Blood is a very, very heavily regulated commodity. And I put it that way because, that's really what it boils down to. The problem becomes one of time and having somebody that can actually be a donor for that particular patient. There are some studies that show, and especially in the San Antonio area, they say that they have a walking donor pool, is their terminology for that. But at the same time, I just see so many regulations that I see as kind of a hindrance. And once again, the biggest question that I always have about this is how often is it going to happen? In a combat situation, that's a very high number of trauma patients.
Well,
And
and actually, I just read a study that was put out about how it's a very low occurrence that even the U.S. is doing blood transfusions on patients in a combat zone, but like the benefit outweighs the risk. So it's a very
yeah,
low pool of patients, but the benefits are there.
yeah, and I always have trouble with this in my own mind because, just like Jane was talking about, I have a heart for the rural areas. And the truth of the matter is that the areas where I think that these things probably can have the greatest impact are also the places where they're the least likely to happen. And they're least likely to happen there specifically because of the fact that they happen so infrequently. But at the same time, because of that time factor, it can actually have the greatest impact. Um, at the same time, if you had asked me even 5 years ago about ultrasound in the field, I would say that it's going to be very limited. And so far it has been, but it's gaining steam at this point. But it has been out there in the field for well over 15 years now in some services, including one that's very close to me. But I have always looked at it as, for that, there's a lot of equipment involved that at the time was very expensive. But as cost has come down and some of the utility has improved, who can say? I don't see that happening stateside in a civilian setting for quite a while, probably more because of liability factors, you know. So you give a blood transfusion to somebody and they have a transfusion reaction and it isn't recognized in the field as promptly as it should have, then there's a liability for that. And unfortunately, there's no way around that part of it. Now, when you're in the military, you don't sue the doctor. You sue the federal government, and they have to give you their permission for you to sue them. So, that unfortunately plays a big role in deciding some of these things. And first out, and the next part of that is it's also still very new in the civilian setting. So, I can't say what may happen in 5 or 10 years, but I don't see anything like that happening for at least that long. Did that answer your question?
Yes, it did. Thank you.
Okay. So Juan asked about give dextrose sub-Q. Yeah, don't do that. If it's given that way, what can be done? There's not really a whole lot. Now, when you're talking about giving dextrose sub-Q accidentally and causing necrosis, you're talking about a concentrated form of it. Now, if you're giving 10% dextrose or 5% dextrose and that infiltrates, that does not cause a necrotic area. Okay. But if you're giving 50% dextrose and that does extravasate, that can cause necrosis. Now, it's not every time, but unfortunately, there's not a lot that you can do about it other than trying to prevent it by being sure that you're giving it in a large IV that is running well without extravasation before you do that. Also, be sure that when you start the IV that it's not one where you went through the back wall and then as you were pulling back on the catheter, then you got some flash and so then you float that in because that will extravasate. And that's more a technique sort of thing. Frankly, I've taken D50 out of my ambulances. And part of it is because of that. The other biggest part was actually that we couldn't get D50. It was on national back order. So I actually switched over to D10. It takes longer to give that way, and my crews don't necessarily like it. But the patients actually, if we're giving them dextrose because they're hypoglycemic, they actually say that they don't feel as drunk after they get the D10 as they did with the D50 because you're not getting these huge fluid shifts. So, Chris, I think what you really mean is labeled uses versus off-label uses. And so there are a lot of things in medicine that are considered off-label, meaning that the drug or device is not truly labeled for that particular use. And so those are things where the FDA has said, listen, we are not going to tell a physician what they can and can't use necessarily, with a few exceptions. And it's up to them, and they bear the responsibility if they're using something off label and there's an untoward side effect. So here's a great example that's going on right now. And that is, using ivermectin or hydroxychloroquine for COVID. There, in my opinion, there's a lot of good evidence that says that it's safe and that it may help. And there are several physicians within my own group that are saying you should never use those. Well, I took hydroxychloroquine when I had COVID, and I took it because I started getting a little bit of a cough and it went away. Okay, so my N is 1. But at the same time, there is a lot of anecdotal and also controlled evidence for both of those drugs that say that it is effective, and especially in combination, the two of those. But those are off-label uses. So if there was a bad outcome, potentially there could be liability. But at the same time, there's a lot of literature to support the use of that. Now, let's use something that was in the lecture, TXA. TXA is one of those drugs where use of that for epistaxis is an off-label use, for hemoptysis is an off-label use, for trauma is off-label. But at the same time, there is enough data, there's enough studies of that particular medicine to where if there was an untoward event, we could say that, okay, that is probably not due to that medication. And in that particular setting with that particular patient, that would still be considered the treatment of choice. And so there is some protection there. So that really, I don't know if that answered your question about on-label or off-label use.
It does, yes, sir.
Okay. So Carlo. Well, it has to do with the receptor binding and the degradation. And so all of these are a little bit different. That's the same reason why with certain drugs that people take to get high, that some of them have a very rapid onset and they also tend to go away quickly. And that's really kind of the same thing with any drug, and that is if it has a very rapid onset, it usually goes away quickly. So that also is why I prefer fentanyl if it's something that's really acute pain, because I know that it's going to work a lot faster. But if there's any kind of a bad problem, they stop breathing or something, I'm not going to have to support their ventilation nearly as long as I would with morphine or Dilaudid. So it has to do with both the receptor binding and the degradation. Now, if you look, in another great example is Narcan. Most of these medications actually work longer than Narcan does. So Narcan is a competitive receptor blocker. So what that means is, with it being competitive, is that it will actually walk up there and shove the drug off of the receptor and then set on the receptor, but it doesn't stay as long. So that's what we're really talking about, is that any of these medications where it's going to a receptor like the opioid receptors, then it's a matter of it binds that receptor and holds on to it for a little bit, and that's what causes the effect. Good question. Yeah, and really it's not a matter, Dustin, of pushing the D50 too fast as much as it is making sure that it's in a good sized IV catheter, that the catheter is in a good sized vein, and that they didn't poke through the back wall with the needle when they were putting it in. Okay, so the difference between these as far as the size of a clot or something is the size of it. And then you also have to understand where that is going to go. So if you're in a peripheral vein and there's a small clot at the end of the catheter, and you push through and you get that to go ahead and flow, that is more likely going to end up in the lungs before it would end up in the brain, unless they have some kind of an incompetency between the atria. So they have an atrial septal defect or something where it can go across. Most of the time that's going to end up if it is going to lodge anywhere, it'll end up lodging in the lungs. But once again, it's such a small clot compared to what causes pathology that really it's not that big of an issue. It's similar to saying an air embolism. If you end up getting some air in the IV line, for it to cause a significant air embolism, you have to have as much basically as the air that would be in the entire IV tubing, because there are mechanisms to help to break those things down pretty quickly. But good question. So non-opioid pain management. Well, first off, acetaminophen and the NSAIDs work differently. So it's not a matter of one or the other. Frankly, I don't have a problem with using them both at the same time. Once again, that was the gist of that study with the children with the arm fractures, was they were getting acetaminophen and ibuprofen combined versus getting an opioid that was given orally as well. So, but good question. Now, they don't both work by inhibiting the cyclooxygenase system in prostaglandins. That's only the NSAIDs. So the acetaminophen works through a different mechanism, and I can't recall that right now because it tends to work in a different manner. But good question. Okay, so John, good question about the glucagon. First off, you need to remember glucagon is converting a form of glucose that's stored in the liver into glucose. So if you have somebody say that they're an alcoholic, that one is not going to work because you have to have that storage form, that glycogen in the liver that is then converted into glucose by the glucagon. So really, and the glucagon also takes a little bit longer to work. So, that one, it's not a bad thing to try, but just keep in mind that that one is probably in some cases not going to work. But it's an excellent question, but you need to, and that's the whole point of understanding how these different medications and things work. Glucagon is actually a hormone. It's something that we produce in our bodies already. So, in most cases, your body is already secreting glucagon to try to get that glycogen back into glucose so that it can be used. So that's the other reason why it may not necessarily work as well. Well, Kyle, good question. First off, there are times that the anxiety level is going to be relieved somewhat by use of an opioid. And so that's one reason to use it. Additionally, what if the patient has already taken 600 milligrams of ibuprofen? You can't give them more at that point. What if they have already taken, a gram of Tylenol? Same thing. So, once again, it's a matter of not seeing everything as a nail because the only tool in your toolbox is a hammer. It's being able to look and say, okay, the patient's already taking these things, or they're taking Mobic, or they're taking one of the other things that you cannot give an NSAID with, and making the decision to say, okay, well, I'm going to approach this pain from a different direction. And that's really the difference, is that you're saying that I'm going to try a different approach to the pain. And frankly, it's one of those that is a matter of, I guess you'd say, experience as well. Over time, you're going to realize that there are some things that, frankly, giving the patient something that is going to depress their sensorium a little bit may be a good choice. Believe me, if I have a femur fracture, please give me morphine. Don't give me Toradol. The other reason, obviously, for that is the platelets. You want those to keep working. But it's once again, it's a great question. Anything else? Y'all are giving me really good questions. I really appreciate that.
It's been a good group tonight. Hey, Jane, we just got dispatched on imminent delivery. Ooh, have fun with that. Okay. Well, everybody, thanks very much for coming tonight. I believe I've got, because everybody participated,
Hold
I
on.
think I've got all the credits granted. Uh-oh.
Juan just put in one more question. Dehydration,
Okay.
saline, or LR? Okay. Man, you ask, that's a lecture in itself. That's an hour by itself. But let's just make it really simple. Are you talking about, are they going to be admitted by medicine or by a surgeon? If you're talking about a surgeon, they're going to want the LR. If you're talking to a medicine person, they're going to want the saline. And in actuality, there probably is very little difference at all. One thought is that saline actually worsens acidosis, where the lactated ringers or other balanced salt solutions do not. So, but it's a good question. And yes, I have actually been to hour-long lectures on that one question. Okay, I think that's it.
Okay. I think, okay, LR. All right. Thank you, Dr. Phillips. Thanks, everybody. And
All
I
right.
believe our next roundtable is Monday night with Dr. Eschelbach. And then I think we have you back next week as well, Dr. Phillips, right?
Yep.
So we will see you then. Thanks, everybody. Good night.
And we'll have pretty snake pictures then.
Awesome.
Good night.
Can't wait.